Cool. So this week, so for the month of April, we're covering acute injuries. And so we went through on-field injury care, and then we went through modalities, kind of the off-field care last week. And then this is kind of progressing out of that, getting into the early stage rehab, and really the first few days post-injury, but really starting to get them moving. So give the overview. This is kind of my thoughts and the way that I conceptualize early stage rehab. This isn't necessarily backed by research or evidence, but this is just kind of the way that my brain makes sense of it all. So the purpose of the early stage rehab is to really set yourself up for success later down the road. You're not going to make or break a rehab in the first day. Like, most of that is going to be rest, but what you do in the next 2, 3, 4 days can definitely have an impact on those shorter term rehabs. And it's the same, it's just a stretched out timeline for the longer term rehab, things like ACL. So what you do in the first 3 days, 5 days probably isn't going to make or break the ACL rehab, but what you do in the first couple of weeks could. So really what we're trying to do is do everything, cover all of our bases, and then set ourselves up for success later so that the rest of the rehab process is smooth and easy. This is kind of like a general overview, so it's pretty basic. So maintain range of motion and strength. So after you have an injury, obviously you're going to have some kind of pain, some kind of swelling. So really you're going to lose some degree of strength and you're going to lose some degree of range of motion. So that's why I put maintain as opposed to improve. You're trying to keep as much of it as you can in these early stages, to prevent that from setting you back later down the road. If you lose a ton of range of motion, you're gonna have to get it back. So if you can keep more of it in the early stages, then you have less work to do on the back end. Maintain proprioception. This is another one. This one, I suppose you probably could progress depending on the individual. If they have really poor proprioception, you can develop it, but it does take a long time to train. So depending on the time frame you have for the injury, you may or may not have time to do that. But maintaining their balance, their proprioception, their kinesthesis, and just being aware of what their injured joint is doing or an injured body part is doing. From there, looking to maintain or progress the uninjured body part strength. So for example, if you've got a left hand injury, that doesn't stop you from using your right hand. You can definitely still do things, push, pull with your right side. Or if you've got an ankle injury, you can definitely still progress upper body strength, core strength, stuff like that. So maybe you're just, depending on the context, maybe you're looking to maintain it, or maybe you're looking to develop it and make it actually better than what it was before. And then the last piece would be the fitness. So again, you're not going to be able to replicate the demands of your sport in a gym. Like, there's no way around it. You can't put somebody on a treadmill and make them basketball ready. You can't get somebody on an assault bike and make them soccer ready. It's just not possible. So unless they're actually doing their sport, they're not going to be fitness wise, they're not going to be prepared for that sport. So again, similar to the range of motion and the strength, you're not going to make them better than what they were before when they were uninjured. So you're trying to maintain as much of that fitness as you can so that it doesn't drop off, so that you don't have as much to get back once they get back on the court or on the field. Then the last piece for me is the approach you're going to take in the early stages. Are you going to go for more of a pain-free approach and you want them to really rest until it's pain-free? Or are you going to adapt some kind of a pain threshold approach where you're going to say, okay, some degree of pain is okay, whether that's maybe 1 out of 10, 2 out of 10, and there's all kinds of debates about what the magic number is and individualized reporting, and you have to make sense with clinical judgment there. But deciding from the beginning, are you going to go pain-free or pain threshold approach? Any questions about that before we get into it? Cool.
None on my end.
Okay, so breaking down the info just a little bit more detail. Maintaining the range of motion. So there's basically 2 types of range of motion here that you're going to have. One is active and one is passive. Some other terms that I've heard for these are going to be like in the gym space, this is more commonly referred to as mobility for active range of motion or flexibility for passive range of motion. So depending on what your space is, people might call it something different, but active and passive range of motion. And if you've ever worked with any kind of a joint issue before, you know that it can be different, active versus passive. Active, they might be limited. They can only dorsiflex to, let's say, neutral, 90 degrees. But passively, you can get another 5-10 degrees out of them. So what's the restriction there? Is it maybe it's anterior tib strength insufficiency? Maybe it's posterior calf tightness that's restricting them. They can't get that calf to relax enough to have an active contraction on the anterior side. Whatever it might be, you can have a difference between the active and the passive components. So making sure that you're paying attention to those differences, and if there is something limiting, you're addressing it. Joint mobilizations, this is dependent on the pathology. So if they have some kind of a fresh acute ankle sprain, you're probably not going to do a bunch of ankle mobs. You're probably not cranking on that thing and trying to get it to loosen up, because you're just going to either, one, you're going to make the sprain worse, or two, you're just not going to let that ligament scar over. So you're probably not doing those early stage, but you might do them a little bit later. For the strength maintenance, again, you're probably not going to improve their strength while they're injured, but early signs of strength development are usually isometrics, and this is what people tend to do first because it's the safest. It's the least force production out of all of the different types of contractions, and so people really start there. I tend to prefer overcoming isos first because it's self-directed. They can control how much they're contracting. So, for example, let's say they've got some kind of patellar tendinopathy. If they're trying to do some kind of a yielding iso, like a wall sit, they are either able to do it for much longer than the time component and it's not challenging them, or it's too heavy and they just give up and their legs are burning and they quit. With overcoming, you can actually gauge what percentage they're contracting at. So if it's a quad mechanism, then you can either measure it objectively and you can have some kind of a dynamometer, or you can use there's a bunch of different technologies you can use for it, or you can just do a subjective grading and ask them, okay, what percentage are you contracting at? And they might tell you 50, 60, 70, whatever. And then they can progress. So if they start at 70, you can say, okay, next set, let's go for 75 or 80, whatever it is. So you're trying to bump them up when they're doing it, but it's self-directed. They can control how much they're contracting. With the lower intensity, this is pretty standard for athletic trainers. I'm sure PTs do it as well, but this tends to be the ankle sprain is an easy example, because what does everybody do for early stage rehab for an ankle sprain? 4-way ankle with a TheraBand. So it's a really low resistance. Like, there's not a ton of force there. You're not going to cause any kind of eccentric damage to any of the muscles that are involved because it's no resistance. So starting with bands is a good idea because it's low risk. Then you can progress into isotonic stuff, really low weight or body weight. And then you can eventually get into the eccentric component, doing more of the neuromuscular control, getting that muscle firing again. But you're not truly challenging them on the eccentric strength component because you can't load them maximally while they're in pain. Does that make sense? Any questions? Cool. For the proprioception, this is a pretty generic or basic proprioception balance progression. This is pretty much what everybody does. I think it's wrong myself, but it is a way to progress balance exercises. So as you can see, they are on a stable surface on a floor, and then they progress to eyes closed. Then they go to an unstable surface, which I think is much easier than a stable surface with your eyes closed. And then you go into a perturbation. So she's controlling, this is a predictable announced change of weight or change of balance. So she's moving that kettlebell around and she knows exactly where it's going. I added to the end of it reactions because you can do unannounced perturbations where the clinician is actually applying some kind of resistance or force and she has to adjust to it. I prefer, especially in these ligamentous injuries, I prefer eyes closed because what are we trying to challenge? If their eyes are open, they're just relying on visual feedback. So if that's not part of their ability to be kinesthetically aware of where they are in space, which is the definition of proprioception, then we're just challenging their eyes and their vestibular system because they want to stay upright. Whereas if we close their eyes, now they have to rely on what they feel. So they get much more in tune with that body part and where what muscles are firing, what muscles are where the body's slanting, where the pressure is, where the weight is, that kind of stuff. So I prefer the progressions eyes closed, but again, this is a simple graphic as to how you can progress these proprioception exercises. For the uninjured strength, so this is kind of a way of conceptualizing different ways that you can keep them active in some kind of a strength component while they have an injury. So upper and lower, we already talked about. If they have a lower body injury, then their upper is good to go. If they have an upper body injury, like a hand or an elbow, you could probably still load them. Some kind of like a pit shark, for example. You do a belt squat. You load them some other way than with their hands. So you can still get away. You could do even like a shuttle board, like a leg press. There's a million different ways you can do it, but you're conceptualizing it as if they have an upper body injury, we can push them in the lower body. They have a lower body injury, you can push them in the upper body. Same thing with push-pull. Say they have some kind of a soft tissue injury to a quad. Well, their hamstrings are probably still good unless they get a real big stretch in their quad. But push-pull, you can balance them out that way. And then left to right. So if their left arm is broken, you can still do unilateral work. And then it actually has carryover effect. What's the name? It's like the crossover effect where you get left arm strength by doing right arm exercise. I can't remember the name off the top of my head. I don't know, unimportant, but yeah, so you can still maintain your strength better if you're getting some kind of contralateral work. The next piece would be core, is pretty much always on the table, barring any kind of like hernia, sports hernia, any kind of lower body injury, they can do core, any upper body injury, they can do core. So doing some kind of core training, core stability, you can pretty much always do that stuff. Making the most of their time off is definitely something that I propose with all of the athletes that are going to miss significant time. They are no longer training, so it doesn't matter if they're sore. So in terms of the strength, this is why I say that you can maintain or progress their uninjured strength. If, for example, it's a soccer player or a basketball player, their legs are the most important thing, right? And their training is more important than their gym work. So if you put somebody through a crazy hard workout and you fry their legs and they can't train the next day, then your coach is going to hate you. But now in a rehab context, if you know they're going to be out for 2 weeks, you can set a timeline and say, we're going to smoke you in the gym for 10 days, and then you're going to get a lot stronger. And then when you come back, you're going to be better than you were before. Because if you smoke them in the gym the first day of a 2-week rehab, the coach isn't even going to know. They're nowhere near the court or they're nowhere near the field. So you can really start to push them and load them up in the gym if they're going to miss time. Any questions, comments, personal experience? No? All right.
We're currently working. I kind of like work with mostly all athletes at where I'm at. And we're currently rehabbing one of our athletes for right hamstring, I want to say it is. And basically, like, my conversation and my coworkers' conversation is like, we did a lot in rehab. Like, we're not going to do a lot in practice just because we're building up from what we're strengthening. And basically, what we had her at the beginning, we had the athlete do was more of a, okay, you can practice kind of like mechanics during practice, but during rehab, like, we're doing more of the strengthening stuff. And she was able to kind of like bounce back and lose a little bit of time, but not the whole time, if that makes sense.
What sport did you say it was?
Sorry, what?
What sport did you say that athlete was?
Track.
Track? Yeah, so that makes sense. So you're doing a lot more like running mechanics rather than like the true stimulus of like sprinting. I'm imagining this is some kind of a short sprint or mid sprint.
Yeah. 100. I think that's.
Yeah, so you've got a short sprinter who definitely
Correct.
needs like the physiological demands of their sport, and they need the stimulus from those high intensity sprints. But if they're not clear to do that, what else can you do sub-maximally to keep them involved in the mechanical, biomechanical side of things while you're rehabbing the main piece here, which is the hamstring. So yeah, I think that's the technical piece is another element of it. And that's sport specific, obviously, because like basketball players are going to work on dribbling or shooting, for example, whereas a track athlete's working on maybe it's upright posture, maybe it's knee drive, maybe it's block starts, whatever it might be. But
Yeah, the
they
stride.
can be working
It's a
those.
lot of different things. Yeah.
Yeah, good shout.
Yep.
For the fitness, so I said it earlier, but gym-based exercise can never replicate the training demands, and this is true for pretty much any sport. Track and field is a great example because everything they do in the gym is heavy, and they are doing it sometimes slow, sometimes fast, depending on the weight, but usually if they're going heavy, it's going to be slow. Whereas in their sport, they're never running in slow motion. They are sprinting as fast as they possibly can, or at least they're doing sub-maximal drills at some form of intensity, whether that's 80%, 90%, something like that. And some examples that I gave, some kind of metaphor to kind of think about it is people will say like, oh, I'm pretty fit or I'm in shape, but then they go out and they play a game of like pickup basketball and they're like, I'm in shape, but I'm not in basketball shape. Or you can say, like, if you want to get really like sciencey with it, you can say like, I've been running a lot, my VO2 max is really high, but then you get out onto a soccer field with all the change of direction and the metabolic demands of like the lower body, especially, it just, your heart's going to be beating way faster than it would if you're just out for a slow, steady jog. So no matter what you're doing fitness wise, you're not going to replicate the sport. So you're doing everything you can to try to push that capacity and minimize the loss, but you're never going to hold on to it. Like, they're always going to lose some form of fitness. They can only get that back by actually doing their sport. For the pain threshold approach, this can facilitate better outcomes. I'm sure, Dylan, you can probably touch on this with your PT background, but if it's done right, you can actually get better outcomes than if you go with a pain-free approach. And the main difference, at least in competitive sport, professional sport, is pain-free is good, but it takes way too long. You're going to be sat around for 2 weeks before you even get them to start like range of motion stuff because they're going to have pain. So in terms of time loss, like, you just don't have that much time. But also, if you start to do early range of motion, early mobilization, stuff like that, that's been shown to have better outcomes for things like range of motion, strength, for a lot of different injuries. The one that's fresh on my mind is hamstring injuries because I've been reading a decent amount about those. But early mobilization is key in getting those to a pain-tolerated approach. Typically, what I suggest is somewhere in the mild range. I tend to prefer, I mean, like, I'll ask for a general like number, like what would you say it is out of 10? But if they say a number that doesn't make sense, it doesn't align with like a visual analog scale, and they say, oh, casual face, it's like a 9 out of 10. Smiling. Like, no, it's not. You're lying. You didn't understand the question or you didn't understand the scale. So kind of use a little bit of clinical judgment here. Like, if they say it's a 5, but they're still looking really casual, they're moving well, I'm probably okay with that. If they say it's a 3 and they're grimacing and limping, then yeah, probably not. So you have to use a little bit of like reasoning here, but for the most part, what the research would suggest is that somewhere between that 3 and 4 is okay. That's tolerable overload. Whereas 5, 6 and above, especially in severe pain ratings where you're looking at 7, 8, 9, you're probably just causing tissue damage, or you're not allowing the tissue to heal too soon, which is just going to stress the healing response. So you're not actually going to allow them to heal. So especially in those first, 2, 3, 4 days where you're laying down new tissue and you're really laying down scar formation, you want to let that process take its toll first before you start to push some of these things. Anything to add from that, Dylan?
Yeah, I love this scale. I pretty much use it for everybody who sees me, because everyone who sees me is in some kind of pain. So yeah, after every session, I generally like to ask, like, what were we at today? I usually tell my patients that we should be working at like a 2 or 3. Anything higher than that, I generally tend to ease off on it a little bit. And to your point, a lot of that is also knowing your athlete or knowing your patient, because I've had people who are just super tough and try to push through it, and they're telling me they're at a 1 or a 2, but either their form looks really bad or I can tell that it's much more than that. And then I've also had people who will tell me that their pain is at a 9, and then they're looking at me and smiling and telling me how their weekend was. So you got to know your athlete, you got to know your patient, and then use a little bit of judgment in between there too.
Nice. Sounds like it's pretty good crossover between ATs and PTs there. Sally, anything you want to add to that with the pain threshold approach?
Yeah, I mean, that's the route that I usually take. Like you were mentioning, like waiting for them to be pain free, it's just gonna take too long. You're like, the rehab's gonna be prolonged, the time that they're out, depending on what it is, right? If it's obviously a fracture, like, we're not gonna do anything. But I rehabbing, let's say ACLs, back surgeries, like I've had within what the doctor lets me do, like trying to like get that range of motion as early as possible, trying to get, if it's the back, any nerve glides or stuff that are going to make the athlete feel much better, because sometimes like the movement is what makes them feel better the earliest. So sometimes just waiting around isn't even smart to do, if that makes sense.
Yeah, for sure. And I think I had it on one of these earlier slides. Maybe I didn't. Maybe it came out of the research study for this week, but the isometrics are a really good way of getting them to start to tolerate exercise, because you're not going to cause damage. You're not going to cause any strain to the tissue. Like literally no damage can be done from an isometric. The strain so ridiculously hard to cause any kind of, let's just say like hypothetically an ankle sprain. If you're doing isometric dorsiflexion against manual resistance, I promise you, you're not going to hurt them. They can squeeze as hard as they want. They're not going to damage those lateral ligaments unless they go into inversion and stretch the ligament. So in a neutral position where you're testing dorsiflexion isometrically, they're going to get a lot better outcomes from it than they're going to get pain or damage from it. So isometrics are another really good thing for that pain threshold approach, to start to tolerate a little bit of that muscle contraction, neuromuscular facilitation.
Right. And even from your eval, oh, sorry.
Go ahead.
Even from your like when you're doing your evaluation, you're testing, like you're doing monomuscle tests and all that stuff. So like you're kind of like testing that isometric, maybe not for 10 seconds, but like you're testing and you're aware of like, is the athlete actually having pain with this, or is it tolerable? Can we make this the exercise once we start rehab, or what can we do? So it's something that you already have an idea as well.
Right, for sure. Getting those asterisk signed early on, so that you can lay out what that next day looks like, and maybe you can skip some of those elementary stages because you've already crossed them off. You already know they're going to be able to tolerate that. For the literature review this week, there's quite a bit. So the first one is the Steph Curry article. It's actually a GQ article. I read this like, I don't even know, like 7-8 years ago. And I remember reading it and I was just so amused with the simplicity of some guy like came up to him in the waiting room and was like, hey, you just had ankle surgery. You're going to be off your foot for a while. Come work out with me. Let's get your handles better. And like it literally like changed Steph Curry's game. Like that kind of stuff is so cool to me. If the athlete has the right approach, the right mentality to it, there's, especially in these longer term return to plays, when you have 6, 8, 9 months of return to play, like, you know, you're going to be out that long, make the most out of it and try to push yourself to be a better athlete than you were pre-injury. I think a lot of times ATs are trying to get them back to 80, 90% of what they used to be. Why not try to make them better than what they used to be, either in terms of the physical or the technical? So I think that depending on the athlete's mindset, if they're open to it, you can definitely push them and improve the technical side of things. And this is what Sally was saying earlier with the track athlete. For the no pain, no gain kind of argument, the pain threshold approach, this is a good article. It's really simple, easy to understand language, but from the prehab guys, they're pretty popular in the rehab space. And then there's a randomized control trial that was actually the kind of, I think, spur of the argument of pain threshold approach, but pain-free versus pain threshold rehab outcomes. This was for hamstring strain specifically. So Sally, you might want to take a look at this for your track athlete, but just a randomized control trial outcomes in terms of the difference between pain-free approach and pain threshold approach. And then the last piece is another article. This was a research study that I found while looking for this week's literature review. And it was written by two of my favorite sports psychology researchers, Damian Clement out of West Virginia and Mona Arvanian-Barrow out of something Wisconsin. I can't remember the school she's at, but really good sports, like sports medicine, psychology of injury researcher. She published a textbook on psychology of injury. So if you're into sports psychology at all, definitely check out her work. And so that is a study of the different phases of rehab, kind of early stage, middle stage, end stage, return to sport, and what the athlete is likely experiencing in those different stages. So pretty fascinating read in terms of the athlete's responses and descriptions of those stages. The video and media review for this week was the All Blacks rugby. And we talked about this earlier while we were waiting for the call to get started, Dylan, but the All Blacks rugby had a short that was put out on YouTube. It's like 5 or 6 minutes talking about off-feet conditioning, pushing them on they use the watt bike instead of the assault bike, but it's basically just maximizing their power output and how long they can sustain that for from a fitness perspective. So they do a lot of that even with their healthy guys, but it's pretty cool to hear the way that they're using off-feet conditioning, and you can apply this in a rehab setting. And then the last piece was just a really basic ankle proprioception progression, giving different examples of exercises you can choose from for what I would call actual proprioception. So things like cones, where you're shifting your body weight as opposed to just stationary balance, responding to the different load, what they're feeling in their feet and in their ankle as the muscles are contracting to try to stay upright. So really challenging that ankle complex to dynamically balance, not just, oh, okay, I'm going to stand on a pad that is supposedly unstable. So I'm not a big fan of Eric's pads, if you couldn't tell. Any questions before we go into the literature review? Any comments? Anybody else hate Eric's pads and think they're overrated?
I don't hate them, but I will say I've moved more to use the Bosu ball for balance and kind of like landing and doing proprioception that way, as well as including the rhythmic stabilization when I'm doing any proprioception stuff.
I think Bosu ball is an interesting one. It's like in a rehab setting, I don't mind it because you're training the proprioception. If that's a proprioceptive specific drill, I think people misapply it and they're trying to apply like maximal force on it, and you're never going to have max force application on an unstable surface. It's like running on sand. So like if you don't have a stable surface, you're not applying max force, you're not getting them stronger, they're not jumping higher. But if you're truly just training proprioception and landing mechanics, then yeah, I don't.
Yeah, I literally use the side of the ball and I have them start there, and it's either they're kind of like from single leg jumping to the injured leg to kind of like stabilize, or they're going lateral each side so that they can push off the Bosu or land on that injured leg. So they get both things.
Gotcha. Dylan, you like Bosu balls? You like Eric's pads?
I think under the right context, I like both. I agree with you. I think just putting someone on an Eric's pad and telling them to do single leg stance for 30 seconds is definitely not enough. But for like mid to late stage acute ankle sprains, I like to do like a step up with the march and like a 10 or 15 pound plate press. So it's a little bit more because you have to stabilize. It's a little bit more dynamic than just standing on there.
Interesting. I have to, I guess, spend some more time and think my way through that one. But you said in late stage. So like, what's the goal of that exercise?
Yeah. So it also depends on what my individual's prior level of function was. If they were an athlete, then something like that is definitely not enough. But if it's one of my middle to later aged patients who wants to get back to hiking, for example, I think it's a more appropriate level. But I'll usually do a progression. So let's see how you do single leg stance on there. If that's too easy, we're going to do a step up to a march. If you start to get really good at that, we'll do a step up with a march and like a 10 or 15 pound plate press in front of you. Because then you got to stabilize the weight that's out in front of you. It's a bit more dynamic.
Yeah, anything with moving weight as a perturbation, I'm a big fan of, because you have the biofeedback at the same time. Like they're sensing the shift in the weight, and they have to make sense of that. Like their sensory input is saying, okay, well, the weight's now out in front. How does the muscle or the joint now stabilize to off put that? So yeah, anything where you're moving weight or shifting balance, I'm a big fan of. All right, moving on to the literature review for this week. So this was a bit of a less, I guess, lower quality study, but it was a literature review on the different rehab phases and talking about the different publications that exist, because it's not a consistent terminology. People don't have the same terminology for different stages of rehab. So we talked last week about stages of inflammation and how you can correlate the stages of the rehab through those. But in terms of like, what do you call them? Is it early stage, middle stage, late stage? Is it inflammatory phase, strength phase, and then like a return to play phase? So there's different terminology that's used across the literature. And so this paper was really talking about what these different stages are being called, how many stages supposedly exist, and then what are the best practices from the different stages. So for the literature review, their search criteria included 9 studies. 7 had 4 phases described. 2 had 3 phases, and again, they were just describing the different types of sports rehab phases. What their findings were: so phase 1 had different terminology again to describe what phase 1 specifically was, but pretty much everybody universally agreed the main goal of phase 1 is decreased pain and inflammation while maintaining range of motion. So best practices would be some kind of a compress. They didn't specify if this was just a compression wrap or if this was like a cold compress, but some kind of a compress to manage the inflammation. You're doing things like electrical stimulation to modify pain. Same thing with massage. You're not digging in there and trying to manipulate the tissue, but you're just giving a little bit of a pain relief, analgesic. And then the isometrics, this is where I was talking about earlier. Isometrics are a really good introductory exercise if somebody is currently in pain. And especially for like psychologically, what it does is when people start to fear movement, it's a really hard thing to get out of. So if you can get them to just contract isometrically without pain and to even maybe push beyond that to start to see some progress, it triggers this kind of cascade of positive effect where they see the benefits. So isometrics are really good in early stage. Maintaining range of motion, they suggested lower grade joint mobs. This would be things like ankle sprains. Again, like if you've got some kind of a grade 2 and you're worried about it, you don't want to be cranking on it. You're not doing any high velocity manipulations, but you can start to stretch that ligament as it's healing. Especially depending on the timeline of it. If you're talking about a 2-week return to play, then you're probably going to start these maybe 4 or 5 days in and just get that ankle moving properly again so that the scar formation is not limiting or changing their range of motion or how they're moving. Stretching is another one that they implemented in this stage. I'm assuming that this would be relative to soft tissue injuries. They didn't clarify, but I don't know too many people who are doing like low load prolonged stretching for joint injuries. It just wouldn't really make sense. But if you have some kind of a soft tissue adhesion or restriction, some kind of a scar formation, gentle stretching would be the progression here for phase 1. And then they also emphasize the importance of maintaining cardio here. So reiterating kind of what I said is you're not gonna make them more fit by riding on a stationary bike, but maybe you can stop some of that cardio loss that they would have if they were just sedentary instead. And then the phase 2, this is where we'll stop for this week. So obviously being early stage rehab, we won't go all the way through a full return to play, but for phase 2, this is where you start to get into your criteria-based progression. This is what Sally was saying earlier. Like maybe when you're doing your eval, you see that they can already do some of these things. You don't necessarily need to revisit all the way back to ground zero. You can start from where they are. And so they were saying for this stage to progress, you should definitely have decreased pain and trending in the right direction. It's not a fluid linear direction, but If they're 4 today, 5 tomorrow, and then 3 the next day, and then 1 the day after that, that's a pretty good downward path for pain. So non-linear, but you should be making progress. This could be also exercise specific. I know, Dylan, you were saying end of the day, you tend to ask these things, but you can also ask, like, with each exercise, like if you've got 3 rehab exercises planned for that day, you can ask them with each of them. Maybe they don't have any pain with ankle pumps, but maybe they do have pain with single leg stance. And you can track that single leg stance pain over the next couple of times you do it before you progress them to that next exercise. So it could be intra exercise as well as intra session. Range of motion, they were saying you should be at least 70 to 80% of normal before progressing on to stage 3, which they were calling the more dynamic phase. So this is, I think my assessment is this is still kind of table-based rehab or like early body weight rehab. So obviously you don't want to send somebody back out onto the field or the court if they have 70% range of motion, but maybe you can get them in the gym and start to load a little bit. ADLs, they were saying your daily living activity should be normalizing at this point before progressing them into the more dynamic stuff. And then in terms of implications for treatment, you're still doing massage. You can start to go a little bit more aggressively here for soft tissue stuff. You can go a little bit more high velocity, higher magnitude or amplitude with the joint lobes, start to cause a little bit more stress to the injured body part. For the muscle contraction, they were saying it should be a functional muscle contraction. So they shouldn't be antalgic. They shouldn't be avoiding muscle contraction. They shouldn't be isometric only. You should be able to get them through a concentric and eccentric phase of the strengthening. So in terms of what the implications were, they were saying start with the isometrics, progress onto isotonics, things like dumbbells, kettlebells, whatever it might be. And then you're probably using a lot of body weight stuff. So whether that's a squat or a step up, a split squat, some kind of variation there. They suggested to start implementing closed kinetic chain stuff here. And then lastly, implementing proprioception. Any question? I know I'm talking a million miles an hour. Any questions about phase 1 or phase 2? Any comments?
Yeah, I think you had mentioned, obviously you don't want to send somebody back into the court or on the field when they have 70% range of motion. But do you think it's a good idea? Let's say we had 70% range of motion, but maybe we can try to strengthen them through that 70% range of motion while we're trying to get back to 100%, as opposed to waiting until we have 100% range of motion and then starting to get them stronger.
So the question is, do I think it's a good idea to strengthen through what range of motion they have before progressing the other stuff?
Correct.
It's a tricky one. I think it depends on the pathology, because sometimes yes is the answer. Sometimes you would want to maintain as much strength as you can, and they're going to start to just naturally improve that rest of that range of motion by working on the strength. Other times you're going to start to develop some kind of like maybe you get a muscle contracture because you're only working through a limited range of motion. So hamstrings, for example, we know there's a benefit for working a long length of hamstring strength. So if you're not challenging that end range, is that a good thing to start loading them and to strengthen them and progress that like shortened range of motion strength? I don't know if that's the case. I would probably keep the load low and work on the range of motion first before I progress that stuff. For that, again, it's pathology dependent for me. Sally, what do you think?
I would say it depends on like injury and pathology, like you were mentioning. But I've had I want to say I've had athletes return with maybe a little bit more than 70% though, but with some lack on range of motion while we are still improving and strengthening, because I usually like try to combine them the both, if that makes sense. Increasing that range of motion as I am, let's say it's an ankle sprain and it just happened, but like I'm having you do ankle pumps at the same time that I'm like trying to like massage the area, or I'm kind of like doing manual stuff as I am kind of like increasing that range of motion to then have you do isometric against my hand while I'm still trying to like get that swelling somewhat moving, if that makes sense.
The other thing I would add to that would be the individual themselves. So depending on how much range of motion they have, they might have, in terms of like the magnitude of the range of motion, let's say ankle dorsiflexion. Let's say you're going to do like a knee to wall test as a simple measure for ankle dorsiflexion. If they only have like 1 degree of translation over their big toe, 1 centimeter compared to 2 would be like 100% increase or a 50% decrease, right? Depending on which way you look at it. Is that considered problematic just because they don't have a lot of range of motion? Like as a percentage, that looks awful, but as an absolute, that number is like insignificant. 1 centimeter difference. I don't think anybody's holding them out, even if you could have that much of an asymmetry, even if you're healthy. So, in terms of like ankle range of motion, like I think again, it comes down to the specific pathology. Ankle, I'm probably less worried about, although you want to pay attention to kinetic chain. What does that 70% ankle dorsiflexion do for you up the kinetic chain as they're running, squatting, jumping, things like that? Are they starting to compensate now and use less knee, more hip, in order to change their jump strategy or their landing strategy? Because that can cause problems, obviously, up the kinetic chain.
Yeah, that's helpful, and I agree with you guys. I think it's definitely pathology dependent. But Sally, I like your point in the fact that we can try to get stronger in whatever range of motion we do have, and then simultaneously we're also going to be trying to improve the range of motion.
Cool. So that wraps up for the next conversation. Give a kind of recap for the topic. So the point of the early stage rehab is to set yourself up for success down the road. You're not going to do anything really groundbreaking, but you're laying the foundation so that the rest of it goes smoothly. And if you don't do some of these early steps, you're going to have a harder time doing the end stage rehab. Maintaining range of motion and strength, you know you're going to lose that if you have pain or swelling. Oh, my goodness. Is it better? Can you hear me now? Hello, test. No, still can't hear me. Hello. Oh no, I sound like a robot. I thought that was normal. Alright, is it better? Can you hear me? No, oh my goodness, what is happening?
Sally, are you having that problem too?
Yeah, I thought it was just me, but yeah.
Okay, give me 1 second. Alright, is that better?
It's the same.
No, what is happening?
And well, Matt does that. Dylan, the other thing that I was thinking about is like how many people do we see that like their hips, internal rotation, external rotation are like lacking, but that's not their injury, right? So like, are we holding them out because of that? Like that wouldn't be the reason why I hold them out, especially if their injury is not at the hip. So continuing to, yes, work on that range of motion, but also like strengthening, let's say it was the ankle and your decrease on internal and external rotation at the hip kind of like has a impact at your knee, and that's why your ankle like we're lacking because some muscles are not strengthening the way that they need to, or whatever the case might be. So I think it's pathology, but like Matt was saying, like kinetic chain, like you have to look above and under to see like how that looks. Same if it's the ankle, like the foot, how's the greater toe mobility and all that fun stuff.
When you have an acute injury like an ankle sprain, will you generally take a look all the way up into the hip and knee just to rule that out as a possible cause too?
So depending on the mechanism, if I don't have a mechanism, I like to look at greater toe mobility, maybe look at where's that tibial rotation, maybe look at where the talus is at. If they're having some discomfort in the anterior portion of the ankle. Also, like, are the muscles that kind of like origin or from the knee, like how are those muscles looking and all that stuff. If it's the knee, I would go ankle and hip. And shoulder, I would go thoracic, mobility, scap, and elbow sometimes, depending on what I'm looking at.
So generally, one joint above and one joint below this site of injury.
Yeah, most likely.
That is a proper basketball athletic trainer if I've ever heard one.
I try my best.
Is my voice fixed?
Yes, it is.
Okay, so my computer has this great adaptive feature and it tries to like limit background noise and then it ends up just ruining everything. But yeah, so the kinetic chain up and down is pretty common. One joint above, one joint below, pretty common for ATs. Did you do any like FMS, Sally?
I did it. Like, I took some classes at school, but like about that. Like, I want to take the actual training to be able to do it. Yeah,
because they're big on that as well, and both in terms of like assessment, like what is theirs, SFMA, I believe.
SFMA, yeah.
And then the FMS screen itself, they're big on above and below. It's not just always the limited body part. But yeah, good discussion on all of that. So moving into the rest of the recap, now that I don't sound like a robot, the maintaining of proprioception, kinesthetic awareness, because you're not probably going to improve somebody's quality there. They're either aware of where their body is or they're not. They are either clumsy or they are agile. And then in terms of the uninvolved body parts that are developing the strength over the rehab, mapping out the timeline. A lot of times you can work backwards there. You can start with how long they're going to miss or their estimated time of return, and then you know how much time you have to build a strength block around that. But you can really push somebody in the strength department if they're going to miss significant time. And then fitness, again, you're probably not going to improve it over the course of an injury, so you're maintaining that. And then utilizing the pain-free approach versus the pain threshold approach. Sounds like we all do the pain threshold approach. That tends to be a better process for, at least for athletes in a PT setting where you've got maybe elderly population, maybe they respond differently to load, or maybe they subjectively report differently than athletes. So you might have to modify depending on your patient population, but for the most part, athletes are going to respond well to a pain threshold approach, and you're going to lose a lot less time that way. Any last comments? Anybody want to wrap anything up?
I will say I have currently an ACL rehab right now, and the position that we put her in, which was like she got injured, I want to say in February. We did rehab because she didn't get surgery till March. So we did kind of like rehab, a lot of like strengthening, range of motion. And at the beginning, she was like, oh my God, like there's a lot of like discomfort. Obviously, her knee was doing stuff that, like, unfortunately, the ACL is not there. So, like, we have to get other muscles to activate, getting the range of motion back, getting that swelling out. We included BFR. And when the surgeon that actually did her surgery, saw her, I want to say 2 weeks post op, he was like, I can't believe you're 2 weeks post op. And like right now, a week, I want to say a week and a half after, maybe, she was able to be out of the brace. And like, I think, and I've said this to my athletic training students, it's like you're setting up something at the beginning of that rehab. And I think that was super important for her. And even she says it as well. The other day she was having pain, kind of like in the medial aspect of her knee. And I was like, okay, let's start with the simple exercises. Let's see how that feels. And even like utilizing that pain threshold, and kind of like, okay, you're having pain, how's it feeling? The same. Okay, let's do foam rolling, let's see how that feels. And after doing foam rolling, oh, it feels a little bit better. Okay, then we can add a little bit more of load. How does that feel? Oh, the pain is like still there but not as bad, and it's not the same. Like, it's a little bit less. So I'm like, okay, so now at the end, after we did all the exercises, let's just do like feel good stuff. And like that just keeps them on a, oh, okay, like I can work hard, I can feel better though. So like it's kind of like a two-way street, and they're like, oh, like this is gonna make me feel better, and I'm still strengthening and doing the stuff that I need to do.
I don't have anything to add to that. 10,000%. Yeah, I agree.
Yeah, that's awesome. I think it's great because Matt had kind of touched on this earlier too, but it shows the athlete that she doesn't have to be fearful of movement. And I think there can be a lot of issues that compound when someone gets scared to move, right? And become more sedentary, and your fitness will start to decrease far more than if you just had the injury. So I think that sounds like a really good plan.
Yeah, I'm trying my best over here.
It sounds like you're doing a great job.
We try. It looks like you're doing a great job, Dylan. I have to follow you on social media. If you have any PT stuff, I'll definitely follow along.
Yeah, Pete, please do. I don't post a whole lot of PT stuff. I graduated in December and passed my boards in January, so I'm still fresh out here. But it's been a really good 3 months. I feel like I'm learning a lot really quickly. And
Nice. Well, congrats on the graduation and passing.
Thank you. I appreciate it. I did my last clinical rotation in Houston with the Dynamo, so that's where I met Matt, and I've just been trying to keep up to date with all the new AT and sports information. So it's been really helpful.
Yeah, that's nice.
Cool. So that's it for this week. Next week, we'll go back to the Tuesday nights, and then the topic is travel complications. So talking about acute injuries that happen on road, some of the different things you might need to consider. Sally, I'm sure you will probably have lots to contribute there. So all your basketball travel will come in handy. So if you can make it, love to hear your experience with acute injuries on the road.
Sounds good. I worked once with the women's basketball national team for Puerto Rico, so definitely acute stuff there.
Awesome. Hope to see you guys both next week.